Assalamu alaikum, everyone. Welcome to our Zoom meeting. Today, we will have a couple of items that we will discuss, and the team with Dr. Lujain will be presenting. So when you are ready, Dr. Lujain and your team, please take it from here. Thank you.
Okay, so today is February 21st, Saturday, and today we will be discussing interesting topics such as osteoporosis, AI and its useful prompts, and how to paraphrase using AI without getting detected, as well as cultural competence. But unfortunately, I don't think Dr. Malaz will be presenting today, and I was informed a few hours back, so I tried as much as possible to actually present something to compensate as well. And we hope for her quick recovery as well. She had a medical emergency, so just so everyone is informed. So yeah. So if Dr. Khansa is ready to present our first topic for today, which is osteoporosis, go ahead, Dr.
Hello, hi everyone. I'm just gonna share my screen. Just let me know if you can see. Can you see the presentation now?
Yes, Dr. I can see it very clear.
Oh yeah, okay. So today I'm just gonna present osteoporosis. So I'm just gonna start with.
Wait, Dr. Before you start, can you please put it on full screen? Thank you.
Oh yeah, sorry.
It's okay.
Here we go. Just gonna do a full screen. Oh yeah. So I'm just going to speak about osteoporosis. So I'm going to start with the definition of osteoporosis. So osteoporosis is a worldwide disease and characterized by reduced bone mass and deterioration of bone architecture. So it can result in increased bone fragility and a higher risk of fractures. The prevalence of osteoporosis is expected to rise significantly in the future, and due to aging population, it mainly occur in postmenopausal women and elderly men. And there is approximately 200 million people are affected by osteoporosis, with around.
Dr. Khansa, sorry to
Yeah.
interrupt you.
No worries.
And I think the slides are not shown. Can
yeah.
you share the screen again? And
Yeah. So
make sure it's a presentation, not the slides.
So is it obvious now, or?
It's the slides. So the slides where you edit, but we want to see the presentation, please.
Oh yeah, sorry, just a minute.
So if you hit slideshow up on the top menu or down, yeah.
So is it obvious now, or?
Yes.
So bad with the technology.
Yes.
Okay.
Yes, you are doing fine.
There we go.
Thank you.
Okay. So I'm going to go back to the previous slide. So for osteoporosis, it's approximately 200 million people are affected by osteoporosis, with around 8.9 million fractures occurring each year. So this fracture mainly involve the hips, vertebrae, and distal forearms, and are also associated with significant morbidity and mortality and reduced quality of life, partly due to common morbidities in affected patients. So osteoporosis also places like a major burden on healthcare system because of its increase in economic cost. According to WHO, osteoporosis is defined as a skeletal disorder characterized by bone strength leading to an increased risk of fractures, and is diagnosed when the bone PMD or bone mineral density is 2.5 standard deviation or more below that of a healthy young adult. So if the T-score was less than minus 0.25. So osteoporosis can be defined to primary and secondary types. Primary osteoporosis include postmenopausal, type 1, and senile osteoporosis, which is type 2. And secondary osteoporosis, it's if there is another like secondary diseases or malabsorptions, medications, or the patient is on steroids for a long time, or hyperparathyroidism. So I will focus mainly on the diagnosis and treatment. So diagnosis, osteoporosis is a silent disease that often remains undetectable until a fracture occurs. So early screening with the DEXA scan or dual energy X-ray absometry is important to prevent fractures. Screening is recommended for older adults, postmenopausal women with the risk of factors, and individuals with the fragility fractures. So for the PMD is measured when the T-score, which is comparable to the young healthy adults according to WHO criteria. So normal T-score if more than -1, and osteopenia from -1 to -2.5, and osteoporosis if it's less than -2.5. So rescreening intervals depend on initial results, and that depends. It can be 1 year and it can be up to 15 years. So that rescreening intervals, it depends. So if it's 1 year for advanced osteopenia, so I'm starting from downwards, and 5 years for moderate osteopenia, and 15 years if it's normal or very mild osteopenia. So the goal for the treatment, the goal is to reduce fracture risk and prevention and management. So it's a kind of like combined treatment. So first to prevent falls, vision correction for geriatric patients, safe homes, avoid sedating medications, exercise, improve strength, balance, and bone health, avoid smoking and alcohol, and ensure adequate calcium and vitamin intake according to daily requirements, which is for the calcium 1,000 to 1,200 milligram per day, and vitamin D 600 to 800 international units per day. So estrogen replacement, it mainly for postmenopausal women, and it's help prevent bone loss after menopause. It's not a first-line treatment and have different risk factors, including heart disease, breast cancer, stroke, dementia. And for bisphosphonates, it's a first-line treatment for osteoporosis, and it's like aldronate, risodronate, and zoledronic acid or Zometa, and it works by reducing bone reabsorption and increase bone mineral density. So it reduces vertebral fractures, hip fracture, and all fractures. And side effects, it's common the main side effects is GI side effects, which is esophagitis. And there's rare side effects including atypical femur fractures and osteonecrosis of the jaw. And it's avoided in severe renal impairment and low calcium patients. So after stopping the therapy, the main concern is rapid bone loss can occur. That's being followed with the calcium levels and with blood rise. So treatment duration usually reassess 3 to 5 years, and as far as I know, with the Zometa usually like it's a 3 years infusions usually. So for denosumab, or called Prolia, and have different brands. So it's a monoclonal antibody, and it usually block rank L. So it inhibits osteoclast, and it results usually decrease bone reabsorption and increase bone mass and strength. So it reduces vertebral and hip fractures and non-vertebral fractures. And the main side effects, it's very rare to have GI side effects or femur fractures or osteonecrosis of the jaw. So that's a benefit to the denosumab, but can cause infections, rash, because usually it's being given as injections. So it can cause infection, rash, eczema. And treatment-wise, it usually stop after 5 years, but I saw it's usually can continue for life for the denosumab. And sometimes it's followed by zoledronic acid, or sometimes they start with the zoledronic or Zometa infusions, and then after that can continue with the denosumab. It have higher like in treatment-wise, better than the bisphosphonates. So there's a new one. It's called strontium relinate. It's increase osteoclast formations and decrease osteoclast. So it mainly help with the resorptions, and it improve bone mass quality and strength, and reduce vertebral, non-vertebral, and hip fractures. And it have a main side effects with the cardiovascular risks, which is not helpful with the elderly patients or geriatric patients, and have GI symptoms, headache, seizures. So it's usually avoided in heart disease or stroke or coronary artery diseases, and usually reserved for severe osteoporosis when other treatments are not suitable. So for teriparatides, it's an anabolic PTH analog, and it increased bone formation and use in severe osteoporosis. So usually if the T-score less than -3.5, and or patient who usually failed the bisphosphonates. So it usually also reduce vertebral and non-vertebral fractures, and main side effects: nausea, dizziness, hypercalcemia, and usually supposed like a baseline parathyroid and immunoglobulins with the teriparatides, and it's contraindicated in high bone turnover and malignancies, and use limited to 2 years because of the risk of osteosarcoma in some studies. For romosozumab, it's a new anabolic drug, but it's still under clinical studies. So it works by increasing bone formation and strength, and it's anti-sclerostin antibodies. So it usually reduce fractures, vertebral fracture by 73% and clinical fracture by 36%, and also reduce non-vertebral fractures. And it's been studied in postmenopausal women with osteoporosis, but I haven't seen if it's been like used or not, but still under clinical studies. So in conclusion, osteoporosis is a skeletal disorder characterized by compromised bone strength leading to increased risk fractures. It's defined as PMD like less than -2.5 standard deviation or more below the average value for young healthy women measured with DEXA. So it's mainly for osteoporosis. It's a multidisciplinary and mainly for adequate calcium, vitamin D, proteins, and exercise and healthy weight, and avoiding smoking and prevent falls, which is the main things with the osteoporosis. And treatment needed if the patient had to hip fractures or start to have fractures on osteoporotic PMDs or osteopenia and high risk fracture. So yeah, that's it. Thank you.
Thank you, Dr. Khansa, for this is a really relevant topic, specifically with the elderly, like on the third decade of life, specifically for us women. Apparently, our muscle mass decreases quite a lot, so this also contributes to osteoporosis as well as the estrogen later on. So it's a really, really relevant topic, specifically for us women as well. So if there are no further questions regarding this topic, and if anyone would like to discuss anything, feel free. Or any questions for Victoria?
Yes, I have a question, please.
Yes, go ahead.
Yeah.
Yeah, so I'm asking for is it like systematic to give all elderly people supplementation of vitamin D to prevent osteoporosis? Because of my previous experience, so I saw like almost the most patient that they consult, they had the deficiency in vitamin D. So is it like systematic, or we have to do the lab before?
So, so in regards, it's a tricky question. I was working initially before in rheumatology. So if the patient had, so usually there is a daily requirement for the vitamin D and the calcium. So if a patient presented for, say, like an elder woman, and she had kind of like, if she didn't had any fractures, and she had DEXA scan which showed like mild osteopenia, so in that, like, we just prescribe like combined for the calcium and vitamin D. But otherwise, if a person is healthy otherwise and he doesn't have any like bone pains or like any it's just like mild osteopenia, we just go with the daily requirements for the vitamin D and the calcium. But yeah, usually the first line is the combined calcium and vitamin D if that patient have a like mild osteopenia. I hope I answer your question.
Yes, thank you, Dr. Khansa. Thank you.
I do have a question actually, but more towards like Dr. Nader, because he's a geriatrics consultant. Or how many patients do you see per day with regards to osteoporosis? Like, is it super common in the US, or is it different for over there? Because I know that women go through a lot of that, but do you see a lot of it?
Sorry, I couldn't hear the question. Sorry.
Okay. Am I heard now?
No, my phone, my mic was off by
Oh,
audio, but go ahead. So
yes,
repeat.
Dr. Nader, I just wanted to ask you as a geriatric doctor, like how many patients do you see with osteoporosis? Is it like as common as we think, or is it like really that common? Is the most common case, or like
Yeah, in my practice, yeah, I see a lot of patients with osteoporosis, and there are a few who has complications, and we see patients who have some falls, fractures due to fragile bones. So we see that in practice, yes.
and what do you advise them to do? Because I heard in a study that they said, like, specifically when an elderly falls down, this can lead to the rapid deterioration in their health. So what is the advisable thing specifically if they fell down? What is an advice here?
So falls by itself, it's a big topic. Falls with osteoporosis, if they are lucky and no fractures, then you want to assess, and as mentioned, you want to prevent as possible the progression of this disease. So the best thing is to educate before all this happen. And if there is in the 50s or so, you test, and if there is osteoporosis or osteopenia, then you want to add this preventative approach, either supplements, avoiding risk factors, or adding some of the medications that may help the progression of disease to be slow or to reverse it, so the bones will be stronger. In case of falls, the patient will not end up with fractures. So this is the general approach, if that makes sense. Thank you.
Okay. Does anybody have any other questions? Feel free. If not, then Dr. Another day, would you like to add something?
Great presentation. But thank you so much, Dr. Hassan. Yeah,
Thank you, Dr.
excellent.
Thank you.
Okay, thank you for the great presentation, Dr. Nader. Dr. Khansa, if Almar is ready for presentation number 2 and 3, talking about the examples of AI, useful AI prompts, and we have how to paraphrase using AI without getting detected. Take the stage. Thanks.
Hello, good evening, everyone. First of all, Ramadan Kareem. Second of all, can you guys hear me?
Yes.
Yes, loud and clear.
Okay. Okay, so for my presentation for today, it's basically going to be these two topics are actually, they come hand in hand. So I thought it would be interesting to just put them together because we usually use, let me just share my screen. Okay, is the presentation visible?
Yes, it is. Can you put it on full,
Yes.
full screen? Yeah, full screen.
Okay. Okay, let's put it on full screen.
Yes.
Right.
Thank you.
Okay, so this particular presentation is going to be talking about two things regarding AI. It will talk about the prompts, and it will also talk about the paraphrasing. So we're going to be taking a look at prompt engineering for high yield research and discovery, because we use AI a lot these days when it comes to research. So it's important to know how you can formulate your prompt in order for you to yield better academic results than your usual engine search. The next thing you have is humanizing AI output to maintain academic integrity and bypass detection. Now, this particular topic, I am honestly a little skeptical about because we've never really had an AI detector that was actually fully authentic with the way it detects the material, but we're going to take a look to see how close we can get. So the first topic is the prompt. Usually, when we have a prompt for a particular research that we want to talk about or we want to research about, sometimes our prompt fails us. It doesn't exactly give us what we want. And there are a couple of reasons for this one. So it's usually due to mainly three things: the lack of persona. You're not really giving your prompt a role. You're not telling it to talk to you as a researcher or as a doctor of a particular specialty. You're treating it like a search engine, like the same way you Google a recipe. So it's going to give you something general. It's not going to give you something specific from the point of view of an academic persona. Second of all, lack of constraints. We've heard of this, that AI usually hallucinates a lot. So if we don't give it limits, if we don't tell it exactly what are the things that we don't want and the things that we want, it's going to be a very vague output or outcome, sorry. Last but not least, we have the black box problem. We don't really give it steps. So when we don't give it steps, it kind of skips the important logical steps needed to yield the results that you want. So for example, let's see an example as to why it fails. So lack of persona. If I tell ChatGPT or Gemini to, for example, tell me about the side effects of beta blockers in the elderly, it's usually going to give you something very broad. It's not going to give you any resources. It's not going to give you anything specific. So the output is going to be like this. Beta blockers can cause dizziness, fatigue, and cold hands. They're used for heart rhythm and blood pressure. Doctors should monitor patients. We obviously want more than that, something more scientific, something more study-based. So here, it's not giving you any doses. It's not giving you any clinical correlations. Nothing specific regarding the side effects, regarding what exactly you want to study. The next thing is lack of constraints. So if we just, usually we always want to hit the word mark, like the word count mark. So we just say, write a long introduction about the importance of nutrition in dementia. Once again, you're not specific. Here, the output is going to be: in modern era of medicine, nutrition stands as a pivotal testament to the comprehensive nature of well-being. It is profoundly important to underscore that, long story short, there's no information, valuable information for you. And it keeps talking and talking, like it just keeps talking and saying filler words that are not going to be of any importance for you regarding your research. Last but not least, we have the black box problem. For example, what is the best treatment for a 90-year-old with AFib and a high fall risk? Give me a citation. So the output here is going to be: the best treatment is this, this, and that. The resource is this, this, and that. Sometimes the resource doesn't even exist. So when you're not strict with AI and you tell it to be specific, I want you to cite actual references, actual studies, base it off of that, it's just going to give you nothings. So it's going to give you hallucinated resources, especially when they're not going to specify. So these are the problems. How can we prevent them? Obviously, we give AI a role, we give them limits, and we give AI the steps. So there's kind of this recipe wherein you don't ask it as an engine, you direct it as a fellow. So you don't just ask it, oh, what is this? You tell it exactly what you want. You tell it the mission, the action, specific context, the way it should think, the logical thinking, exclusions, and what you hope to yield from this particular prompt. So for example, here we have some examples. For example, for the mission, you're going to tell it directly, your mission is to find a research gap in current anticoagulation protocols. In the actions, you need to be very strong with your language. So you're going to tell AI, critique this particular thing, contrast this and that, draft. If you're going to give it a vague term, it's going to give you vague results. You have to be specific with your context. Once again, inclusion, exclusion. We want to include patients that are over 80. We want to exclude patients that are this and that. So these are really important things to keep in mind when it comes to formulating your prompt. Now, here we have an example of a bad prompt. Write a literature review on frailty and heart failure. It's going to give you the most basic Google generic information that is not going to be of importance to you for your presentation, for your research. Wherein if you use the master framework, we are going to specify exactly. Like here we said, mission, identify 3 specific areas where current research on frailty is lacking. We specify the action, we specify the context, we tell it the way to think, and we include the exclusions and what are the results that we're hoping for. And I will send these 2 outcomes just so that you guys kind of can see the difference between those 2. As you can see in the first prompt, which is the bad prompt, which is very vague, it just literally tells you the definition and things that you cannot use in your research that are going to be important. But here, it's going to cite the information, it's going to give you doses, it's going to give you names of medications, actual studies. So this is why formulating your prompt is really important when it comes to research. But the problem doesn't only stop here. Say that we formulated a good prompt, we extracted the information that we needed. How can we bypass the AI detectors? The truth is, doing research on this particular topic, I kind of discovered that you will never be free from the shackles of AI telling you that this is AI generated. If you have good language, if you're actually writing it in a scientific proper way, there's always a risk of it actually telling you, yeah, this is AI generated. So before we move on to the first topic, to the second topic, I hope everything is clear with the first one. If anyone has any questions. Okay, so we're gonna move to the next one, which is how to humanize and paraphrase. So usually when we paraphrase something, it basically means that we're trying to rewrite it. We're trying to bring the information that we know, put it into our own words to give you the final information or the final product. So why does it usually fail, paraphrasing? Why does standard AI paraphrasing usually fail? First of all, there's this thing called statistical uniformity. So it's going to give you, as I said, vague information, and it's going to write it in such a way that sounds robotic. Second of all, the flat rhythm. Usually in AI, whenever you ask it to paraphrase something, it's going to give you almost the same length of a sentence. So you're going to notice that every sentence is almost the same length, almost the same way it's written, the same tone. There's no variety in it. The third thing is the thesaurus trap. There are particular words that are going to be used, and then they're going to say that it's paraphrasing, when in reality, it's just really synonym swapping. So instead of saying important, you're going to say pivotal. Instead of saying this, you're going to say that without changing the actual structure of the sentence. And logical thinking. As quote unquote smart as AI is, it will never replace the actual experience that you have on ground, the actual experience that you have in your own wards, in your own rounds, in your own hospital. So the more you personalize it, the better. So this is why usually when we paraphrase using AI, it fails. So why is humanizing important? First of all, for the safety of your research and the ownership and the academic longevity. Of course, whenever you're flagged multiple times for actually using AI-generated research, it's not going to look good on your resume, and it's going to jeopardize your career. So that's why humanizing your research, making it personal, and breathing life into it is really important. So let's see how we can do that. First of all, we're going to look at the personal perspective. Once again, when you put your own experience into it and your own words into it, it will obviously be different from an AI-generated research. Second of all, the variable rhythm. As I said, AI usually has sentences that are exactly the same length. So when you have a variety of that rhythm, it's less likely to detect it. The exclusion prompting. You can actually tell AI to exclude particular words or exclude particular things that are included that make it look like it's an AI generated research. Last but not least, the reversed outline. the most ethical way. When you have your whole thing together, take one last look at it. The truth is, you can never escape the fact that you have to reread your material, even if AI helps you. You have to reread your material, you have to put your own touch into it, and you have to make sure that there aren't any hallucinations, because AI is known to hallucinate a lot. And how can we prevent, or at least have these hallucinations lessen? By the things that I mentioned with writing your prompt. So here I have a demo. This particular demo looks robotic, generic. Every single sentence is almost the same length. So after I tried to humanize it, this is how it looks like. So it looks completely different. Here, I don't really have any studies to back up what I'm saying, but here I included a study. Second of all, the way that I introduced this is different from in the realm of geriatric medicine, it is pivotal. I said, frailty isn't just a checklist, it's the clinical reality we face every morning on the wards. Once again, personalized. But I tried to humanize it in another way, because the truth is, as I said, if you have your particular piece and it's written very well, AI is most likely to tell you that, yeah, that's still AI generated. So the only text that I put in these AI detectors that actually gave me 100% human is this one. And if you read it, it's going to be so different from the first time that I tried to humanize the demo that we included. It's weaker. The readability is kind of low, so it's not really that good. So this opens the question of, can we actually rely on AI detectors when it comes to our text? And the takeaway of this here is the most important thing is the human being reading their things, making sure that they have their own touch into their material, and to not rely completely on AI, because it still has a long way to go. There was actually a study that they did at Stanford that they realized that AI detectors were actually biased against non-native English writers. So can we actually trust the AI detectors? Regardless, there are things that we can do to improve or give us the information that we want at the end of the day. But yeah, that's it for AI detection, how we can bypass it. I mean, we can try to bypass it, and how to write a useful prompt. Thank you so much for listening, and thank you so much for your time. If you have any questions, please go ahead.
Okay, thank you so much, Dr. Almar, for the great presentation. So, does anyone have an experience with AI that they would like to share, or any questions for Dr. Almar? Okay, if not, then I will be proceeding to the next topic, which is about the cultural competence in healthcare. If that's okay? No more questions? Okay. So I'm going to be sharing my screen. Can everybody see my screen? This my screen seen? Hello?
Yes, Dr. Lajay, I can see your screen.
Okay, thank you. Okay, so today we're going to be talking about the cultural competence in healthcare and providing equitable care to diverse population. So the goal of this presentation is actually to build an understanding on how to deliver respectful and effective care across all cultures with all different ethnicities. And, regarding the political climate, specifically in the States, it doesn't even matter if you're in the States and the Khalij or anywhere in the world. You will find people with different cultural beliefs as you, and it's simply important that we are flexible and open-minded, specifically as doctors, because we don't get to choose the patients to treat, and we treat everybody, do no harm, right? So okay, so let's start with the stark reality of health disparities. So let's go to the main problem in this. So we have to start with addressing the issues in health or in the communities in health, right? So this is not just statistics or something that we hear as, you know, in the news, but it's actually a real thing, right? So they represent systemic barriers like cultural misunderstandings, there's language gaps, there's unequal access to quality care, like specifically if you've worked in underserved populations in America, like, or as I said, like anywhere in the world, like you can see all these issues, right? So for example, specifically in America, we have maternal mortality crisis, like African American women face 3 to 4 times higher pregnancy-related mortality than white women. So there was a research that I had saved, but I feel like I didn't find the I don't know, I lost my file, so unfortunately I won't be able to show that today. But either ways, like this is a huge thing in the US. Like multiple people, like, you can open like a TikTok page and you would find like a TikTok actually complaining about this, and in which some doctors tend to have biases over like, you know, how Black people apparently are more equipped to handle more pain than white people, which is obviously not true and rather kind of racist and biased, right? The second thing is chronic disease burden. So you have diabetes and hypertension, which disproportionately affects more Hispanic and African American communities due to lack of access. You also have a research, which is the mental health challenge. Native American populations face significant mental health challenges, experiencing elevated rates of substance abuse and mental health struggles. So all these are very real and not just a statistic. So yeah, it's important that we hear about them and discuss them. So what exactly is cultural competence? At its core, it is the ability of the healthcare providers and organizations to effectively deliver care, no matter the cultural background the person has, the religious background. It shouldn't matter, right? You're a doctor, you're meant to treat regardless of, you know, the differences. So culture in itself is a broad topic. We can't just put culture as one thing. Like in Sudan, like, you know, there are different cultures even within Sudan, right? So it encompasses languages, you have beliefs, you have customs, you have traditions, you have social context, and even like through generations, there's different contexts, like how Gen Z can speak in another social cue, right? So all of that is, you know, in a way, we're meant to be flexible and also even understand and adapt to the way that our patients speak, per se. Like, as I said, like there are colloquial slangs as well. So what are the essential components to this? You have attitude, right? Which requires openness, respects, self-awareness about different cultural beliefs. And you have knowledge, which we must actively build on to understand. We have skills as well, the practical abilities to work cross-culturally and adapt care accordingly. Okay. So why should we even care, right? How does this impact? It has a direct correlation. So you have better communication, right? So it provides trust with your patient, right? Leading to a much more honest conversation. And your patients are more comfortable to open a dialogue about their health concerns, right? Specifically, if they trust you, there's a greater satisfaction. The patients are happier, they feel more relaxed with you, they feel comfortable, right? They don't feel like they're being judged. And it reduced barriers, as I said, like comfort and rapport in general. We all know rapport, right? So we have respecting patients' cultural and religious beliefs. So patient care fundamentally means listening and adapting rather than, you know, putting every patient in one box and assuming that, oh, I can just talk to each and everyone with the same monotonous tone. No, as I said earlier, like it's patient care. It should be patient-centered, in which the patient, regardless of cultural belief, regardless of religion, regardless of skin color, we should be able to adapt regardless to all of that. Like right now, we're celebrating Ramadan, in which we fast for a long time, right? And this does not mean that care is inaccessible for us in the Western countries. No. And as well as like we have Jewish patients as well who eat kosher. We have vegetarians all around the world, or vegans. So we should be able to direct the care according to the patient's what do you call it, culture/preferences as well. So there's also traditional healing practices, like we should be able to acknowledge traditional medicine, prayer, and complementary therapies. Like per se, we have different beliefs. Like as I've said, like us as doctors, we are Muslims, right? And so our patients could not even believe in a God, but this does not mean that we will take away care just because we don't believe in the same God. So our main goal is to do no harm, as always. You have modesty concerns as well, like honoring preferences for same gender providers. Like some women don't feel comfortable being under a male doctor or a male nurse. So we should be able to respect that. And their family decision making. A good example of this is when a patient or an elderly is sick, some cultures may prefer not telling the patient, and rather than judging the patient, we should have an open mind, actually. If anyone has studied for USMLE, like we've all heard the same ethics again and again on how to like deal with the patient and being open-minded. Okay, sorry about this. Okay, so building competence requires like actionable strategies, right? First, we need regular and evidence-based cultural competency trainings. Like physicians should be aware of the different cultures that are around them. The second is workforce diversity. Well, it's in the US or here in Saudi Arabia, we see like different nurses/doctors with different backgrounds. So this helps us be aware of different kinds of things, different kinds of backgrounds, different kinds of beliefs, which is actually amazing that we have in today's age. So third is community partnership. So we have to engage with local community. Like, so the local community will give you a good background of the locals in general. And like just dealing with them, we are able to understand the cultural needs and the barriers of that particular community. So the fourth is data-driven action. So we must collect and analyze data on health disparities. We have research, and research, which is why this is so important. So what are the challenges in cultural competence and how do we overcome? So first of all, yes, doctor, you have to be willing to be, as I said, open-minded, right? So it's a give and take. It's a give and take. So we need to learn from our success and our mistakes, like to just be vulnerable and like, allow yourself to learn, right? You say, oh, I didn't really know that vegans completely don't do something or something, or like per se, like you've never heard of a particular caste in India, right, in which they don't eat particular food, and you should be open-minded to that. Like I will say like a particular event in which I felt like I was actually ignorant about someone's cultural background. I had a friend, and she was from a particular Hindu caste, and apparently she did not eat any type of animal at all, and nor did she kill. And I actually have never heard about this, but she educated me about it, and it was actually really interesting. So just having this conversation is really important to getting familiar with new backgrounds that are actually like very different from yours. And then you have language access. Sometimes, you have to address language barriers with professional interpreters or translated materials and multilingual stuff. So, I believe there is like an easy access, at least in the States, with what do you call it? Sorry, the word completely left my mind. The one translating.
Interpreter service?
Yes, interpreters. Yes, yes. And then you also have institutional integration. Well, you can add it in institutions. So embedding all of this in the administration, you should have it as a policies in the hospital, and continuous adaptation. Like every time there should be an updated, an adaptation to the evolving community and the demographics, right? So yeah. And then not only is this with the clinical outcomes, you will not only see this in a positive value in the clinical outcomes, not only is your patient happy, in the business and the ethical case for cultural competence, this is amazing, right? Like everyone's happy, they are gaining money, you're making your patient happy, everyone's happy, right? So you have the financial benefits, as I said. So you have, it reduces costly health disparities and improves quality metrics and decreases the preventable hospital readmission. So you understand your patient, they come to you less, and everyone's happy. You have the patient loyalty. They're going to be happy, you treat them, they understand, you remember them, you understand their issue. And yeah, the ethical imperative, it aligns with ethical imperatives of respect, equity, justice, and healthcare for all. As we said, do not do any harm. And it is supported by the national standards of US national and culturally and linguistically appropriate services standards. So this is this is a standard that maintains like cultural and linguistic services in the US. I don't know how about in any other place in the world, like what do they use for adaptation of different cultural backgrounds, but in the US they do have this standard. Okay, so moving forward, like to close this, how can we keep on advancing as doctors, as IMGs, you know? How do we keep on being better? So we can commit to lifelong learning, as I said, open-mindedness, specifically in places in which like there are different backgrounds. It's just allowing yourself to, you know, put your beliefs behind or put it aside and actually communicate with different types of backgrounds. You can engage with respect, obviously, talking to different patients and being genuinely being curious with their background helps a lot. And to advocate for change, right? And closing the gaps as well, research, so that we know exactly what population we're dealing with and to eliminate the disparities if ever. So yeah, I hope you guys like learned a lot with how to be culturally competent, specifically with, you know, today's political state. And yeah, any questions or any conversations that you would like to add about actually meeting with a patient that was culturally not the same as you, and you learned something from them? Anything that anyone would like to add? I'm done. Thank you for listening.
Thank you so much, Dr. Lujane. This is a really, really interesting topic because since communication now is easier than ever, be it between a patient or a doctor, it's also more common to have misunderstandings. So this is a really important topic to shed the light on. But at the same time, I feel like these days, especially with the prevalence of like more means of communication, we're able to understand one another more. So hopefully, as you said, with what's happening in the country, especially in the US, we hope that people actually move forward with our role as doctors to genuinely just be there to help and nothing more.
Thank you, Dr. Lujane, for this important topic. Yeah, cultural competence is very important in the US due to the big diversity in this country comparing to the countries where we came from. So, but I think the advantage we have as a doctor that we are already like we learned about ethical behavior, and we know how to behave with patients, like to deal with him as a patient, any like without looking to the religion and or social situation or anything else. But just like we have to be careful with some points when dealing with patients. And also I see like there are some people that can face like depression when they came from other country with different social culture. So I think it's an important topic that we have to give attention to it. Thank you.
Yeah, thank you, Dr. Arim and Dr. Almar, for your comments. If there's anything that anyone would like clarity on or any questions, I'm free.
Thank you both, Dr. Lujain and Almar, for great presentations. These are important topics, and hopefully it will help each one of us. If there is any question for any of the presenters, please go ahead. Now we can move on to the update section. Any new ideas, any questions, any progression of your projects, research projects? I just want to share with you a good update. We have two fellows in Washington State. They have been accepted to one of the programs there. They have their unique program as far as accepting IMGs or graduates without going to residency. So they go to be in training under supervision, but they can practice. And the good news is after 4 years, they can be eligible for board exam. They can sit for family medicine or internal medicine board, and they can be certified in that specialty. So congratulations to them.
I have a question, Dr. Nader, please, concerning
Yes.
the fellowship. Yeah, is step 3 recommended to be accepted in a fellowship program?
So most of the program, they require that, from what I know. So it's a good thing if you have time and if you can study, take it. So number one, if you have a spot open for residency, you will be more than the other candidate to be accepted, because it's a headache for most of the programs when they accept new residents. They want them by the first year, they sit down and pass the step 3. If they don't, then they will not terminate them actually, but they will put them on a side. They cannot continue to go to second year unless they pass that exam. And that means for the program, they have an open spot. They need to figure out how to cover that. So it's easier for the program to get someone for the first year, but it's difficult to get a second year position filled. So for them, it's a plus if you have step 3 and they can accept you instead of other candidates. If you only apply for fellows or fellowships, then I think most of them, they will accept you if you have step 3. I'm not sure if there is some that they don't require that, but from my experience from this program, that fellows from here went to fellowship in geriatric, nephrology, and infectious disease, They are required to have the US status, like either a US citizenship or green card. They need to have a step 3 and some clinical experience back home. Some, they say 2 years at least, maybe some experience here in the US. But this is what our fellows in the past, they applied with these requirements. Thank you, Dr. Reed.
Thank you, Dr. Nader.
Oh, Dr. Nader, what's the difference between actually applying for residency or later on in fellowship? Like, is there an advantage to actually like starting in the US, or like is fellowship going to be easier, or am I allowed to, if I skip the residency and I just did the fellowship in the US, does that allow me to work in the US or not? Just complete the fellowship and I have to leave the country. How is it exactly?
So you ask a very complex question. So I'm gonna handle it in a step manner. So to divide it. So basically, the routine or the usual way, you go to residency, and then if you want to, you can do the fellowship afterward, and you can do as many fellowship down the road. So in my case, I finished internal medicine. I did 1 year of geriatric. The other way people do, like international medical graduate, they can come and join a fellowship in their area. Let's say I did cardiology in Saudi Arabia, and then I passed the exams, but I didn't get accepted for residency. So I can apply to some programs who can accept me in cardiology because I have experience in this area back home. Then they will accept me directly to the fellowship. So the question is, some of these fellowship, they will accept you for 1 year, or it depends, you can do it, extend that to 2 years or more. And then if you finish the first year with them, then they say, oh, we are done, let's say. Then you have to find out another program. Either you go back to the residency, so you apply to some of the open position, or like in the match, you apply as a candidate for residency. But the benefit for the program is that you already have 1 year of experience in the field, let's say geriatric or infectious disease, and they can see you as a good candidate to join the program because you already know the system, you already know the clinical aspects of knowledge and so on. So your chance of finishing the program and passing the board is higher than other candidate. Or you can do extend the fellowship in the same area. Some of the fellows did that. Or you can do a different fellowship. So you can move on to, like you did nephrology, you can apply to geriatric, or you can go to infectious disease, whatever. So these are ways of doing it. Some of the programs, if they give you 2 years, then some states, they can let you practice with unlimited. So you will be an independent physician, and you can practice. You can join some of the hospitals, or you can start your own business or group. You can join some groups in your area. As far as these new programs that are in some of the states where they accept you in training as a physician, but you will be working under supervision for how many years? In Washington, for example, we have a fellow from this program who joined Washington program there. She's in her 2nd year. So they contracted her for 4 years. So she will do geriatric medicine for 4 years. After that, she can be eligible. Now it's approved to sit for the board exam. So she can do a periodic board exam, or if she wants to apply for like internal medicine board exam or something like that, I think she will be eligible. But the idea is you can practice after that. Either you want to work in a hospital, in university setting, or as a private, or you join a group. So this are different ways of doing it, if that makes sense. Is it clear for you? Thank you.
Yes, thank you so much. This is a very important topic. I actually did not know about this pathway. How important is the year of grad? Because I graduated in 2024, so I'm planning to apply for the 2027 match or 2028 one. And so I'm thinking that this is too old. I mean, people have said that, oh my God, your year of graduation is a mess. So, what do you think about this?
So let me ask you, which state you are in? Are you in the state or outside?
I'm outside the state. This is the problem, a big problem.
Okay, so my suggestion is if you are coming to the state, let's say you have a green card or you have some way of getting, try to find out a state where they already passed laws to have these new programs. I think there are at least maybe 7 or so. One of them is Washington, one of them, I think, is it Minnesota? Anyways, there are some states that offer these programs where you join a group and you can practice under supervision as a doctor. And then after a few years, you can be eligible either to practice on your own or you can sit for the board. So this is one approach. The second approach is you do the residency right away. A third approach is there are ways of the fifth pathway or sixth pathway where I think it's also different. Some applicants go through these different pathways. So there are
Okay.
more than one way to come to the US to practice.
Okay, thank you so much.
You're welcome.
Thank
And
you
there
so
are
much.
some programs where they can accept you on unique way where they can show the US government that you are on top of your field, for example, and you will be beneficial, something like that. Thank you.
Doctor, how about USCEs as like, is an observership worth it or is it not worth the time? Like they've said that an elective is way better, but I don't know if an observership is actually worth the time and the money, or is it not?
I think it's different from one program to another. When they say we want a US experience, what do they mean by that? And some offer just observership, some offer like an elective, or some nowadays I think it's kind of tricky, but any kind of exposure to the system, whether it's just you round with some of the doctors here, is good experience for the programs, because at the end of the day, they want you to know how to handle patients, taking history, how to do an exam, proper exam, the way they do it here in the US, without causing problems or discomfort for the patient or the family involved. The second thing is they want you to know the system as far as, let's say, EMR. So if you are in a clinic, you round with your doctor there, then you see how they put their note in, how they order, how they consult, how they do scripts, and so on. So if you get familiar with an EMR, Epic is one of the big EMR. Then if you put that in your resume, you had an experience or observership or clinical. Then with that also you have exposure to this type of AMR, and then they can accept you because you already know these two aspects, because they're gonna train you, but if you already know some of the basics, then it's easier for them, if that makes sense.
Yes, thank you so much, Dr. Nader. Actually, my first exposure to the EMR system was through this fellowship. One of the fellows actually gave a presentation about it, and until this very day, I actually remember it because it's super relevant. Like in case I want to do my residency there, like it actually does prepare me for the future. So thank you so much for that.
You're welcome. Anytime. Thanks for this question. Any other questions or any other updates, comments, or new ideas?
Yeah, so in regards to
Yes.
the fellowship, I applied for 2 fellowship programs,
Mhm.
but because I'm overseas, I'm in Ireland, so I think because of the visa restrictions, it was both geriatrics fellowships. So I think they were trying through, there's a kind of like exceptional, remarkable something they apply for. And I got accepted for both, but because of the visa and all those kind of things, they were kind of like, they're not gonna proceed with all the things. So I think for the fellowship, it worth it. I don't know about the current situations, but yeah, for the fellowship, it's a kind of like there's many programs they got back to me and they were asking about mainly the visa and yeah. So hopefully,
Oh, doctor, can
Yeah,
I
with
ask?
all these changes,
yeah.
political things, happening. Go ahead. Yeah.
Doctor, can I ask you like a kind of private question, Dr. Khansa, if that's fine with you?
Yeah, that's okay. No worries at all.
Like, are you a dual citizen?
No, I'm
Even
not a
with
dual citizen. I'm in Ireland 3 years. So if I'm dual citizen, I think that's gonna be more easier.
Mhm.
Yeah.
oh,
So
so they didn't allow you because of the Sudanese passport?
yeah.
Oh, oh. Well, hopefully you find a way, or hopefully things get better for us.
Yeah,
Inshallah,
let's
Hopefully.
wait
inshallah,
for time will tell if hopefully
Yeah.
things will change.
inshallah.
Yeah.
Inshallah.
I have a question for Dr. Khansa, please.
Yes.
Can you tell me which program for geriatric fellowship did you apply for?
So I
'Cause
applied for one in New York. It's called Maymouth, and I applied for one in Bay State. It's I think it's in Springfield. So yeah, that's the both programs. But there are a couple of programs they got back to me and they were kind of like if the visa kind of things, I think things would be more easier. So those are the 2 programs they got back to me.
And do they recommend home country residency?
I did the kind of like 3 years back at home. So I think they don't mention it's mandatory to have the residency, but they want internal medicine for 3 years or more. So that's the main thing. And then it depends on your CV and other things. So yeah,
Yeah, thank you.
no worries. Thank you.
Did they ask about step 3 or did you take step 3?
I did a step 3. I did step 3 in the last moment. Yeah.
Sure, yeah, because as I said, most of the programs it's a headache for them. So if you take a step 3, then you remove that headache for most of these programs.
Yeah.
And I know one of the resident was in a program and she did not pass step 3, and they stopped her from going to from first year to the second year. It's kind of tragedy for like not going there. So it's difficult for the program to fill this gap.
I do have a question, but this is for like everyone or anyone who knows. What exactly are they looking for in the CV other than research, so that we can craft it towards that direction, if anybody knows?
So I think they mostly I thought initially they don't look at your experience, but they look at everything. They look at your experience, they look at research. Research is important, audits and then when I had the interviews with the 2 programs, so they were kind of like they were asking more personal who I am more than it's the CV itself. So I think it depends. It's a tricky question. It's not just about like the research and those kind of things. It's depend on overall. So yeah.
Oh, thank you so much for answering my question. That's interesting that they want to get to know your personality, actually, your overall personality, and not just how your academics were.
Yeah, in both my interviews, to be honest, they were both, and I had the interview last year as well in another program. So it's they asked me more about the war kind of things. What did I do? And my personal statement. They haven't asked me one clinical question and nothing about my research. They asked me one time about my research, but mostly like it's about personality wise. So it depends. It depends from program to program, I think, and it depends what they want from the candidate itself. So that varies. Yeah.
Okay, thank you so much.
No worries. Thank you.
Thank you for sharing. And I want to add more, like I was one of the committee, in one of these committees where we interviews fellows for a fellowship in pediatrics. So as you mentioned, we look at the CV. So there are different parts where we want to look at the individual, like your clinical experience is important, but as well as the research, but the other parts that we can dissect and see if it's true or helpful for you to join that program, for example. We want to see how you are involved in your community or volunteering aspects. How are you doing with your leadership, your personality as far as working with teams, your extra curricular activities? Are you going out of your way to do other interesting things in your life? So these are some of the things that we assess. Some of the programs, when they do the interview, like at our here, we want to see if the applicant was genuine when they say we want to join the program and we want to stay for, let's say, a period of time because we have family, kids, we want to get them in the school and so on. And the idea behind that is if we have a good candidate for the fellowship who will spend 1 or 2 years with us, can join the faculty, and then can be a member of the teaching and the practice group, then it's easier for us to have that instead of having a person who will come to Michigan for 1 year and then go back to, let's say, Alabama or somewhere else where he has family connection. So if they have some roots here in the Michigan area, they want to stay for, say, at least 4 or 5 years, then it's got to be a plus if we compare them to someone who doesn't have connection and they just want to do the fellowship and go somewhere else. So you think about the programs, as one of you mentioned, is personalized, what programs they look at and what they want to gain out of you. For example, they just want you to be taught clinically and you become good and then you go on your way, or they want someone who can help them as well flourish. Thank you.
Oh, thank you so much, Dr. Nader. This is actually a very interesting insight in which, like, I've never seen it in the perspective of program. You know, we usually look at it from one point in which, like, oh, is this program healthy? And type of like, will I be mentally healthy or the type of community? But I've never thought about it as the program itself, looking for someone who they can, lean on to. So yeah, very interesting. Thank you so much.
You're welcome. And you mentioned a very important point where we want, let's say, in the residency, we want you to know how to handle situation where you can work with seniors, with juniors, with your colleague, and not causing problems. Because some of the programs, they have candidates who join them and then they have fights all over, and that's not a good also thing for the program, if that makes sense. So there are aspects otherwise they look at for candidates that can help the program, if that makes sense.
Doctor, out of curiosity, how is this assessed? Like if someone is going to fight with someone based on an interview?
Yeah, so some of the interviews, they will ask you questions about in a situation where you are, let's say, older graduates, let's say. When you join the residency, you will have juniors or seniors of different age. So if your senior is less or younger than you, and you have a situation where you have experience back home and your opinion is different than your senior, how you can handle that, if that makes sense.
Yes,
So
it makes sense. Thank you so much.
situation, yeah.
Thank you.
But from the CV, if you mention that I'm working in this program, for example, telegeriatric, and I'm working with different groups, I was a team leader or I was team member, we work on this together, we publish this, we work on mobile application together. My part was this, I work with 2 other fellows on this. So your story also can tell if you are a team member who can handle tasks in a team based approach, or you are an individual. Because remember, many of the doctors or medical students, when we are in medical field, medical school, we are very competitive, we are individualized, we are A-type kind of. We want to get to the top individually, but in residency and in real life, that doesn't matter a lot. What matters is you focus on the patient as a team. So if you become a cardiologist, you're gonna do a procedure. That procedure, you are not gonna be able to do it alone. You need anesthesia, you need nursing, you need other staff member in the room where they prepare stuff for you, maybe social worker or some other helping people around you. So you need to know how to be a team, either leader, so you instruct, or team member, if that makes sense. Thank you.
Thank you so much, Doctor. Amazing insight. Uh, I do want to ask you a question regarding the projects with the research. So unfortunately, I won't be able to be present for the month of March. And I saw that the submission is on March, and I hope to see my fellow members like publish and submit. But I would like to ask if there's another opening, which is after March, in which I would be able to, work with my fellow members or my fellow researchers. معلش دكتور نادر, your mic is muted.
Yeah, thank you. I think you are always encouraged to participate, even if you take a task with a group. You don't have to complete from A to Z. If you are busy down the road, you can take a task early in the project. If you are busy nowadays, then you can take a part afterwards. Or if they submit in March, but the result or the invitation will be in May, and you will be available in May. And the other way to do it is to participate with the team in developing or making the poster, for example, if that makes sense. So there are different tasks in a project. So depending on your availability, your interest, your expertise, you can pick and choose where you want to participate, what part in the project. That one thing. The other thing I want to share is there's always new research projects. So we can talk about how you can develop your own, how you can develop your team in that research part. Let me share with you something now. So we had a presentation today about AI and about other topics. How, if we want to use AI to generate a mobile app for fall prevention, I think what we can do is we can look at the gap. Is that an area where you can develop an app that can be useful, or there are a lot of apps saturated field and we are not going to be able to add more? So that might be a question for all of you if you are interested. So one of you might look up, maybe I can just pinpoint. Reem, you can look up fall apps in App Store, Google App Store. Almar, you can do the same. Look for app that handle falls in other type of stores, like we have the two Android store or Apple store, and look up and see how, if there is a lot of apps in this area or a few, and see what's the features in each of these apps, and then think about, oh, they didn't talk about this, or they only in English or whatever, but we have some gaps, so we can do what in Arabic or what in different language, or this is a gap, they are only like based on pictures, there's no videos, or they are only exercise based, no educational based, or they are only after the patient is falling what they do. Now there are not a lot of them of prevention, how to fall safely, for example. So if we identify the areas, then we can come to the AI and say, hey, list us 5 ideas of a mobile app for patients for either 1, 2, 3 items. Let's say prevention with exercise with this and this and this. The same way, I think one of the presenters, Almar or Al-Khansa, mentioned about the giving the AI the good prompt. So it will list ideas of programs for us, and you can pick up one of these ideas. Let's say first idea is very good. Then you can ask the app to see, or the AI to see how we can develop this app. It will say there are 2 different ways, this way or this way. So you pick one way. Most of the time, the app will be displayed like on the screen, and the interaction will be like buttons where the user will click. It's got to be shown as video, image, or text, or audio sometimes. So the feature that you want to bring as new features, you're gonna say, I want the app to show this. If that makes sense so far. Any questions?
I have a question, Dr. Nader, about the project of abstracts for IMGs. So
Sure.
I want,
Go ahead.
yeah, I want to join to project number 4, but I couldn't contact any one of the members. I couldn't add my name to the Google Sheet. So do you have any idea about it?
Okay, let me get to that. Just a second. Give me a second. I have to look at the. Do you have the link for the? Can you share it in the chat? I have to figure it out where I saved it. I can do that just a second. So I'm going to share project 1 for now, and then we can move on to the other project. So I'm going to share the screen, and then we can. So for example, this is project 1. So were you able to go to the author list, Reem, like similar to this one here?
No, when I open the link, it doesn't show me the names of the members.
So were you able to go to any of these tabs, or even the app, the Excel sheet or the Google sheet is not opening for you?
Hi.
Mhm.
Go ahead.
I opened the number 4. If you would like me to add you, I'm not personally in the list because I didn't want to. I didn't know that I could join if I just use if I even contribute the slightest. But if you would like, you can write down your name, your contact, and what role you would like to do, and I will put it down for you, and I will send you the contact list of everyone in that group.
Okay, thank
you
you,
would like.
Jane. Yeah.
Yeah, no worries. You're welcome.
Yes, thank you.
Excellent. Thank you both. Any other questions or? New ideas? Not, I'd like to thank you, Dr. Lujade and your team. Thank you all the presenters for today's meeting. Great presentations. Thank you all who attended today's meeting. I also would like to thank those who will watch the recording in the future. Thank you and have a wonderful day. We'll see you next week, inshallah. And if you have questions, please reach out, either email, text, or call me. We'll be happy to help as much as we can. I wish you all the best and Ramadan Mubarak. Assalamu alaikum.
السلام
عليكم
عليكم.
السلام. Thank you Dr. Nadir. Ramadan Kareem. صوم تفطر على خير.
مع السلامة عليكم.
مع السلامة.
Thank you.
Thank you. شكرا.
Thank you, Dr. Nader.
Thank you so much. Have a good one.